So I'm just going to cut to the chase very quickly in this. I won't go through the same level of detail for case number 2, but I just want to emphasize a few important points about the second interesting case. She was age 35. She had 2 previous miscarriages, previously did 18 cycles of ovulation induction, followed by 1 failed attempt at in vitro fertilization. So she came for her first visit, and that's the details of her history. And our clinical impression was polycystic ovaries. And most people would, because her cycles are 38 days, and she had a hyperstimulated cycle when she went for IVF. But most people would say, what are you going to do? You're going to do more ovulation induction. She did it for 18 cycles. She's done that. Have some compassion for this girl. Move it on. There's nothing you can do to help. And we would argue there are things that were missed with her previous ovulation induction that we can do better with a restorative approach, a multifactorial restorative approach working with the fertility chart. So I won't go through all the details of everything we did because of a little bit of time pressure. I will give you the summary that 18 cycles of ovulation induction, 3 cycles with letrozole, 8 cycles with clomiphene, 7 cycles of FSH injections, a hyperstimulated IVF cycle. So she started the whole process when she was 33 years old and 3 months and finished it when she was 35 plus 6 months, 2 full years, no success. And then she comes to us. It was also in January of last year, 2022. Male factor was good. The bloods were consistent with polycystic ovaries with a high AMH and LH reading higher than FSH, but quite suboptimal progesterone levels. I don't know what stage of the progesterone curve that was taken, but that's low by anybody's standards, which is probably why she'd so much ovulation induction. Most people I see won't get that amount of ovulation induction. So what we found for her, we did her diet and her supplements. I don't think she needed naltrexone. I wanted to test her for insulin resistance. We found the insulin resistance. I gave her insulin sensitizing treatments. I gave her supplements. I added vitamin B12. I usually add that with the glucophage because it's at risk of going low. And our diet for polycystic ovaries is avoid dairy, wheat, and sugar. So we implemented that to begin with. And this is really important because this can help to improve egg quality before we boost and balance our hormones. So this phase 1, diet, supplements, insulin sensitizing medications, do this first for about 2 months before you start to boost and balance the hormones. So phase 2, when we boost and balance the hormones, here's a real interesting chart. She'd little or no mucus at all, no vulvar wetness, no visible discharge, and it was a urinary assessment that allowed us to identify an LH surge, and we checked her blood 7 days later. And often with polycystic ovaries, you get near normal progesterone levels, but it still is poor follicle function in this case. So on her second cycle, we still haven't commenced anything like follicle stimulation. It's still the medications I outlined with the insulin sensitizing treatment, but the mucus is starting to appear just a little bit now in tandem with the temperature rise and her LH surge. So it's getting a little bit easier to pick it out. And this is where I see her at review. She's got 2 cycles and I go, right, here's what we're going to do to boost your hormones. I want to put you on 7 tablets of letrozole for 2 days, because the usual thing we discover is inadequate follicular stimulation. We find they respond better with a low dose of prednisolone if it's PCO, and then we do luteal phase progesterone, monitor the impact by ultrasound and bloods. Again, now our incidence of twins were running at about 2%, but these cases happen to over-respond a little bit as it turns out. And it turned out also by follicle tracking, she produced 2 follicles, both of them ruptured. We verified that by ultrasound. The mucus was a lot better, and we verified 2 follicles, both of them rupturing. So we overdid it just a little bit, and her hormones were also a little bit high. So 10 letrozole might have been a better starting point. I think I went a little bit heavy-handed. Positive test, very first cycle. Now, 18 cycles of ovulation induction before. We did 2 cycles of getting her metabolism right, 1 cycle of follicular stimulation. Now, potentially we could have a twin pregnancy here. And remember, she had hyperstimulation, which is potentially very bad for a woman's health and well-being. And what we did was completely different with this one. People say, we've done all the ovulation induction already. What are you doing? I say, you didn't implement a multifactorial restorative strategy where you get the metabolism right, as well as the hormones, and as well breaking the stresses that go with this, the verbal advice we give is today is the day you stop trying to conceive. And what you do is we'll balance your cycle and you enjoy being together for some of the days to allow fertilization to occur. So I'll go to the bottom line with this. We were able to calculate her due date and we looked at her hormones in advance. I was concerned it could be a twin pregnancy. Her bloods were absolutely fantastic, beautiful ultrasound scans at 7.5 and just about 10 weeks. And thankfully they got in touch with us. They had a New Year's Day baby delivered 1st of January and full term healthy baby, and everything went fine. So thank you for your attention and I wish you all the best. Bye for now.